Here the guy is in the bottom right-hand corner. He had the frame put on his head. Here we are. This is the plan that we do where we tell the machine to aim the Gamma Knife at this location and not anywhere around it. And we know that for acoustic neuromas that if they're under 2 centimeters in size and you do Gamma Knife for it using a dose of what we call 12 gray, there's a 94% chance that at 10 years the tumor will not have grown at all. So it's pretty effective. And the complication rate of it, about 50% of people, if they've not already lost their hearing, will progress to lose their hearing. And the risk of them having a facial paralysis is less than 1%. They don't have the risk of bleeding or infection. They don't have to recover from surgery. So it's pretty good. And so for all of our small tumors, although we could very easily remove something like that with an endoscope, we'd rather use the Gamma Knife. This is basically how the frame goes on. This is kind of, we plan it. The Gamma Knife is done with 3 people. It's done with a surgeon, it's done with a radiation oncologist, and it's done with a physicist. The surgeon's job is to make sure that the frame is on properly, make sure that we know what we're aiming the Gamma Knife at. We've got to tell the radiation oncologist where to aim. The radiation oncologist determines the dose of the Gamma Knife, and the physicist's job is to make sure that the machine is functioning properly. So we work together as a team to do this. The patient lays in the machine. The Gamma Knife itself is actually easier than an MRI. The MRIs are claustrophobic. The Gamma Knife isn't. It doesn't make any noise. It doesn't hurt. You just lay there and it works. Most people wonder if the Gamma Knife machine is even on when they're getting treated because it's so benign. These are the collimators. So the rays are essentially going through these little holes, which are all focusing down onto one point. So tonight we kind of went a whirlwind tour of different types of minimally invasive brain surgeries, starting through the nose and then kind of addressing the rest of the brain. But these are the things that are really kind of the future and actually are becoming the present of neurosurgery. 15 years ago, none of this stuff was possible. It was a pipe dream. It's now becoming reality, and I suspect in the next 3 or 4 years you're going to see even more crazy things, if you will, coming down the pipe. We've been doing it here now for 7 years. We've actually evaluated over 2,500 people in the past 7 years with different brain lesions for possible minimally invasive brain surgery. We've done over 500 of them endoscopically. And right now we were the first program in the Southeast U.S. to be doing this, and we're still the largest. So we're pretty proud of that. This is something that's not done alone. It's a team. Dr. Spector is kind of my pilot. He's the guy that does all the endoscopic and the nasal stuff with us. Dr. Patney is the neurotologist that we often work with when we're doing stuff in the posterior fossa. Dr. Lehman in the bottom right corner works with Dr. Spector. He's usually the backup guy if Dr. Spector is not available, but Dr. Lehman always brings us very, very interesting cases and actually brings some of the most challenging cases, often in the frontal sinus work. I do a lot of that with him. And then last but not least is Dr. Hellinger, and he's our interventional neuroradiologist. So he's the guy that I call frantically if we were to injure a carotid artery to come help save the patient and stop the bleeding. So he's invaluable for us, and without him, none of the other stuff could be done. Great, thanks.